الحرباوي، بروفيسور في تصوير الرنين المغناطيسي ورئيس قسم الأشعة في مستشفى هداسة، ويعمل حاليا في قسم الرنين المغناطيسي في مستشفى الأهلي. سيلقي عليكم محاضرة بعنوان Introduction of MRI، فليتفضل مشكور.
السلام عليكم وشكرا على الانفيتيشن. أنا كثير مبسوط إني في فرصة إنه أجي أقدم هالمحاضرة. راح نبدأ بشوية introduction للنيورو راديولوجي، وتأخذونيش راح يكون المحاضرة كلها بالإنجليزي. إذا في مجال للورا يقدموا شوي بشوفوا الصور أحسن. فبنبدأ بالنيورو راديولوجي، الادفانسمنتس كيف بدينا بالنيورو راديولوجي وين وصلنا هلا، وبعدين ندخل بالام ار اي شوي. ف من الصور انتم شايفين انه بدينا من زمان كنا بس اكس رايز، وطبعا بورجيش كثير الاكس راي. بعدين صار في ادفانسمنت للسي تي سكان، للانجيوغرافي، بعدين we advanced more to MRI. We'll begin with this talk's oriented towards the technologist and how you can help work as a team with the radiologist. The important thing for us as radiologists when we look at just X-rays are what's called the ABCs, which is the alignment, the bones, the cartilage, and soft tissues. This is just the cervical spine, for example. Again, this is a normal cervical spine. It should show from C1 through T1 in a normal X-rays. As you can see here, the alignment is fine until we get to C5, and then you see a step off here. This tells you there's subluxation. In a setting of trauma, you have to assume there's a fracture or a jump facet. So with the advancement of CT, when we see abnormal alignment, and here you can see there's the space between the spinous processes is grossly abnormal. It's widened between the C1 and C2. When we do the CT scan, you could see there's a fracture of the dens process, and there's compression of the cord and severe canal stenosis. This patient's going to be quadriplegic, actually. So you could see even small changes on the X-ray mean big problems on the CT scan. Even a tiny step off right here at C4, C5 can mean pretty dramatic findings on the CAT scan. Here you have a fracture traversing the anterior to posterior dimension of the vertebral body, and it involves the posterior elements, the lamina. Now, fractures of the spine, if it's only involves the vertebral body, it's considered a stable fracture. They don't need surgery most of the time. When it involves the posterior elements, the lamina, the pedicles, it's considered unstable, and they need surgery to stabilize them. As you know, you can do flexion and extension views, which can bring out some of the pathology more. Looking at plain film X-rays, you know, we can see subtle changes. The pedicle's missing here. When you do a CT scan, the reason it's missing is because there's a large osteolytic mass, a metastasis that's destroying it and extending into the canal where it's abutting the cord there. Again, X-rays, they just give us some general pathology, general idea that there's pathology. Here from the X-ray, you see all these osteolytic lesions in the skull in a patient with multiple myeloma. This is a gunshot wound to the head. The bullet pretty much took the top of his calvarium off. This is a parietal fracture. So again, a long time ago, this is all we had. As radiologists, this is all we can work with is the X-rays. Now with the CT scan, we can see if there's the fracture, if there's a depressed skull fracture. On X-ray, just some degenerative disc disease. Here's a hangman's fracture. Again, you see gross malalignment and displacement between C2 and C3. You look for other signs of trauma. Soft tissue swelling in the prevertebral area is a sign that there is serious injury. This is a gunshot wound to the head, to the neck. I'm sorry, the bullet came traversing obliquely and then hit the bone and went the other way. On X-rays, sometimes we don't know what we're dealing with. Is this calcification of the bone, the calvarium, or is it inside? When we do the CT scan, you could obviously see that it's in the brain parenchyma. This is not in the skull. So some of the problems where we need your help from the technologist is to make sure that all cervical vertebrae are seen. Here on this X-ray, you don't see all 7 vertebrae. When we take it, you can see there is a malalignment there. There's a step up. And here, this lady's wearing her earrings. We take off the earrings, we did a CT scan, and she has a fracture of the dens process. So make sure that you take off all the jewelry or anything that might obstruct any pathology. The importance of windowing. When you window images in CT scan, on the soft tissue windows, you get an idea there's some pathology here, but when you go to bone windows, you see all these fractures, comminuted fractures posteriorly and anteriorly. There's things that look like pathology, but they're not pathology. They're pseudopathology. When you look on the dense process on an X-ray, sometimes you see what looks like a fracture line. And that's actually a congenital variant where the posterior arch of C1 is not completely fused. This is a crush fracture, and you can see the vertebral body is compressed and broken up in many pieces, and there's posterior displacement into the canal with compression of the cord. So we finished with X-ray. Now we go to the next advancement after that, which was angiography. Regular catheter angiography gives us obviously greater detail of the blood vessels. This is the internal carotid artery and the circle of Willis. Again, the middle cerebral artery here, the anterior cerebral artery. This is the A1 segment, and this is the anterior cerebral arteries. So you can see from the angiogram the pathology of the carotid arteries. Here you see severe stenosis at the origin of the carotid artery. Here, this is the internal carotid artery. It should branch off into the anterior cerebral artery and the middle cerebral artery, and here you see the MCA is missing, so it's completely occluded. This is the left middle cerebral artery infarction. Other than infarcts and stenosis, the angiogram obviously is good to look for problems with the blood vessels like an AVM or an aneurysm. This is an arterial vascular malformation from the carotid. This is the posterior circulation, the vertebral artery coming up to give off the basilar artery, and this is the AVM, and this is a large draining blood vein going into the inferior sagittal sinus and then the sigmoid sinus here. This is an MRI. This is a tumor, GBM, and you see the enhancement. It's not just peripheral. It's more aggressive appearing. It's really throughout the lesion, and you can see the mass effect and midline shift of the phalanx. What's the pathology here? You have this density, which is really low density, and because there's air in the head, and it's because there's a fracture of the frontal sinuses, and that allowed air to go inside the head, and that's called pneumocephaly. Now this density it's not quite air, but if you look at it, it's the same as the subcutaneous fat, and this is a lipoma. Intracranial lipoma. This patient really has everything here. He has intraventricular hemorrhage, intraparenchymal hemorrhage, subarachnoid hemorrhage, subdural hemorrhage, fractures, the whole deal. This patient, somebody decided to put a nasogastric tube, but went the wrong way, so the tube actually went intracranially and was throughout the brain. So not very good. Anybody see the pathology here? Okay. No, it's a little dark. And you can see he's lucky it didn't hit his orbits, it just went. It's right by the nasolacrimal duct. Okay, the benefit of CT scan is we can do two-dimensional reconstructions and three-dimensional reconstructions. This is an advancement over X-rays. We can see sagittal and coronal reconstructions here. And this is the three-dimensional reconstructions that we can do now. This pathology, it's little knife to the eye. Okay, things to be careful about. Patient motion artifact. This is something you're going to deal with a lot as technologists. A lot of patients, they move, they're not cooperative. That really degrades the image quality and makes our jobs more difficult. The other thing is metallic artifact. This patient has a bullet by his pedicle, and that also gives beam hardening artifact, which you could see throughout here. This is something called ring artifact, and if you see it, it looks like a ring and it's on multiple slices. It's a problem with the detector. This is again beam hardening artifact in the posterior fossa because the bones in the lower and the posterior fossa are very dense, and they give this artifact. Now we advance a little bit to MRI. In general, the MRI, as you know, there's no radiation. It's from the excitation of the protons and then their relaxation. They give off signal that's detected and then reconstructed into images. The general two basic sequences are T1 and T2 weighted sequences is based on the times of relaxation, the time following the excitation of the protons. And they give off different signals that are picked up and reconstructed into images. So a normal head MRI, this is a T1 sequence. Just real general, T1, the fat is bright, the CSF or fluids are white. This is a T2 weighted sequence. You can see the CSF is bright and fat in the skull is dark. And you can see the white matter is dark because white matter has myelin around it, which is fat. This in the middle is something called a flare sequence, which stands for fluid attenuated inversion recovery sequence. It's a T2 weighted sequence, but they suppress the fluid. So instead of fluid being bright, it becomes dark, but everything else is like a T2 weighted sequence. And this one really shows pathology very well. In the spine, again, this is a T2 weighted sequence. This is a normal spine, lumbar spine and thoracic spine. This is a T1 weighted sequence. And this is a T1 weighted with fat saturation. You can see the fat's not bright anymore because it's been suppressed. And you have normal fat in the bone marrow, and that's why. Now, the MRI imaging obviously gives us great detail for neuro, for musculoskeletal imaging, for intra-abdominal imaging. Its most common uses are for neuro, for brain and lumbar spine, for example. Here you see a disc herniation at the L5-S1 level. The other discs look really good. You could also do magnetic resonance angiography. And this doesn't require that you give them contrast, and there's no radiation involved. You get a real good look at the circle of Willis here, and you can diagnose if they have an acute infarct or aneurysm or AVM. It also gives us three-dimensional imaging. So at the same time, we can do sagittal, coronal, and axial imaging. This is a patient with a tumor, an intraaxial tumor, a GBM, with surrounding edema. This is pre-contrast and this is after contrast. You could see the enhancement.
ظلت جنين عصية لا تنحني إلا ركوعا في الصلاة مطيلة كبر الجنين على الجراح وعمقها شفي الجنين ونالت